Good evening and welcome to tonight's webinar. My name is Blake Baucom. I'm the Director of Sales here at Osteogenics. Before we get started, I want to ask you to interact with us today using the chat feature on the right side of your screen. Please feel free to answer any or log in any questions there, and we'll get to you as we can at the end of the presentation. I'm going to introduce Dr. Ramón Gómez Meda. He received his degree in dentistry from the University of Santiago de Compostela in Spain in 1996. He then went on to obtain a Master's of Occlusion and Temporomandibular Dysfunction from the University of Valencia in 1998. Dr. Gómez Meda completed postgraduate training in orthodontics, periodontics, and implantology, and is a former partner in the restorative dentistry, endodontics, and surgery departments at the University of Santiago de Compostela. He is a national and international lecturer on periodontics, implantology, and aesthetic multidisciplinary treatments, as well as the dental XP expert and Zeiss microscope expert. Dr. Gómez Meda has maintained a private practice in Ponferrada, Spain since 2001. Dr. Gómez Meda, thank you so much, my friend, for joining this presentation.
Thank you, Blake. Thank you so much for the invitation. Thank you. I want to thank Osteogenics, also Stephen, who is there at the background right now, taking care of this lecture, and every single attendee. Wherever you are, all around the world, it's a pleasure to be in front of you. I will try to go throughout the lecture, a very short and simple lecture, very quickly summarizing what I do when I practice vertical GBR procedures. I don't have much time to show many cases about horizontal GBR, but I will show, I think, a couple of cases. And so let's start. Throughout this lecture, I will try, as I said, to explain the step by step, the steps I follow when I practice this kind of techniques, and to explain to you why do I place the implants at the same time I perform the GBR procedure. Of course, you can go for the delayed approach without any problem. So let's speak about the principles of vertical augmentation, the treatment planning, and the surgical procedure. This is sorry about the health pressure here. So let's start with the first part of the lecture. And there are some biological principles I have to respect. I need the stability of the gum. And this stability of the gum, I can get it with a titanium mesh, with a bone blocks, or for example, with a non-resorbable membrane, with a titanium framework, like the one you see here on the right side of the screen. Of course, I need also blood supplies, space maintenance, and I have to avoid any dehiscence of the soft tissues if I want to be predictable, if I want to have a predictable result. So, okay. So the first thing I have to consider is how much bone do I have and soft tissues, the condition of the soft tissues, but also what is the patient, who is the patient I'm treating. I have to select properly the patient. I have to consider the habits. If the patient is a heavy smoker, for example, this is not the best patient to perform a vertical GBR procedure. I have to convince the patient to leave this kind of habit. I have also to consider diseases like diabetes or other kind of problems associated with the health of the patient. The anatomy of the bone defect, how many walls do I have there left, the size of the defect, how much time do I need to wait in order to uncover the membrane is also very important. And of course, if I'm not able to release the tension of the flap in the proper way, maybe I will face the main complications with this kind of procedures with non-resorbable membranes. And this is a wound dehiscence. Okay, so I have to learn how to properly manage the soft tissues. I would love my patients to smoke if they are not able to leave smoking, to smoke less than 10 cigarettes per day. But this is for horizontal GBR procedures. For a vertical GBR procedure, I would prefer my patients not to smoke. With diabetes, if the patient is stabilized, I consider that my patients are normal patients, so I go ahead without any problem. And you should consider also other problems. For example, nowadays we have many patients treated with bisphosphonates. In those patients, sometimes you have to say to the patient, please take a holiday from these pills for some months, because if not, we can face complications. On the right, you see a real situation, a patient I treated many years ago, and we had this kind of complication. At the time, we didn't know that the patient had been taking these pills for many years. But when we asked for medication the patient was being treated with, she said, I'm not taking any pills, because she had left the medication 2 or 3 months before. Even so, we had this complication, and you can see that the defect I had, this is a huge vertical defect around 10, 12 millimeters. I cannot remember exactly. And everything went quite well. I didn't have any kind of wound adhesions, but you can see on the right of the screen that when I opened up almost 1 year later the wound, I found out that I had a kind of necrosis around this biomaterial. The bone was not properly healed. I was quite surprised and lucky enough to retreat with the same membrane, the same site, with the implant already placed there. And after another year, we reopened the wound, and we ended up with a very good result. You can see here that the regeneration was complete. So after the first surgery, after the first year, we inquired the patient, and of course we were asking ourselves what could happen with this clinical case. Why this situation? Because it didn't happen to me before. And then we discovered that we should ask the patient if she had been taking any pill, any bisphosphonates before, not only at the moment, but before the surgery. So maybe it's helpful for you in the future, this kind of a story, in order to ask properly the patient, not only the pills she is taking or he's taking at the moment, but also the pills he had been taking lately, because the condition of the bone can be altered, and then you can face this kind of complications. So be careful with the questions you ask to the patient, because they are quite important in order to complete your file properly. In the end, we were lucky, as I said before, and we were able to reconstruct properly the defect. I think all of us at our office face different situations. Horizontal defects, very predictable ones. Vertical defects are a little bit more challenging, and full arch rehabilitations are a little bit different. I will not speak about this right now because I don't have enough time. Of course, this is a short lecture. I started practice with horizontal bone regeneration many years ago, and I jumped to vertical defects very quickly because I started with soft tissue management, and I realized that I didn't have many complications. From my point of view, in my humble opinion, the keystone in order to be successful with GBR procedures is soft tissue management. But of course, there is a huge difference between a tiny defect or a mild defect and a very big defect. This is the classification by Dr. Carlo Tinti. Class 2 defects are the ones with more than 5 millimeters of bone resolved vertically. So these are defects more demanding. So if you are starting with this kind of procedure, you should wait till you have a lot of experience on horizontal defects and mild vertical defects in order to have predictable results. The most important part when you analyze a bone defect is to pay attention where the bone peaks are located. The bigger the defect, the more distance between the bone peaks, the more difficult is to regenerate the defect. The less blood supply you have, the more challenging is the soft tissue management. So, for example, and as an example, in this clinical case, you can see that the bone peaks are very far away one from the other, so far away. So it's more challenging. You can get good results, but you need to reduce the tension of the flap much better. You cannot make mistakes. So this is a little bit more challenging, okay? And of course, the larger defect, the same thing, as I said before. And we all have the same question. Okay, do I go for bone blocks? Do I practice titanium mesh? Or I keep a simple procedure with a non-resorbable membrane, with a titanium reinforced non-resorbable membrane. The problem with bone block is that the morbidity is higher, and that sometimes I don't get the volume of the bone I desire, and as a result, I have to repeat the surgery, and this is quite challenging for the dentist and also the patient. Of course, it's very osteogenic, but we face also complications. With every single technique we have in the market, we face possible complications. Of course, incision dehiscence with every single procedure. Sometimes the graft can be exposed and maybe I lose the graft. The graft can be remodeled. I do not get the bone I wish. And maybe I'm able to, from time to time, I have sensory changes with the dental nerve. And this is quite annoying. So the morbidity is the main challenge with bone blocks, mainly when the bone blocks is very large. When the defect is large, I need to harvest that very large bone block, and this is challenging. Not only the grafting, but also the harvesting technique. It's not the same to harvest a 10 millimeter bone block than 4 centimeter bone block, as you can see here on the right side of your screen. In this paper by Dr. Curie, you can see that in 4% of these clinical situations, the dental nerve may be exposed. And sometimes you could damage the dental nerve. Not if you are careful, but this is a possibility. You can face this kind of problems also, the wound dehiscence, and as a consequence, the bone block is exposed and you lose the bone block. You have to repeat the procedure, as I said before. So let's look at this clinical case I did many years ago. On one side, I decided to use a titanium mesh. On the other side, I harvested a bone block from the mandible in order to get the vertical regeneration. This is the bone block I harvested from the left side of the mandible. I was able to divide the bone block in 3 layers. And after the suturing, you can see the result. And after that, I went for the vestibuloplasty. Okay, several months later, I exposed the bone block. And you could see at the moment that something was strange, because I could see very clearly the head of the screws underneath the mucosa. You appreciate that I don't have any kind of wound dehiscence and not any single problem. But when I opened up, you can see that I don't have the bone I wanted. So what do you do now? Because I said to the patient, now I'm gonna place the implants, but I don't have any bone. So my message here is that you need some other techniques in order to be able to solve your problems, because from time to time we face complications. not a single surgeon is able to practice without any complication. So what I did at that moment is to place the implants simultaneously to the GBR procedure. And I chose them at that moment a non-resorbable membrane, cytoplasm membrane. And you can see that I promised the implants as I promised to the patient. I harvested bone chips from the same side. This is autogenous bone chips. And I mixed the autogenous bone chips with xenograft. And of course, I covered everything with the non-resorbable membrane. So if you pay attention to this clinical case, you realize that this is the second clinical case where I placed the implants immediately in order to solve a complication with the non-resorbable membrane. During the first case I presented before, I had a complication because of a previous medical problem, and I had to regenerate everything at the same time the implant was there. This is before and this is after. And when I open up the wound, you see the bone I got. I have to uncover the implants because the implants were fully covered with bone. I overcorrected the regeneration with a collagen membrane and a little bit more of xenograft bone chips. And this is the result I obtained. And afterwards, I ended up with the implant supported rehabilitation. You can see on the other side that I didn't get an optimal result with the titanium mesh. And this is the reason with the years I abandoned that technique. And I practice nowadays only bone blocks and non-resorbable membranes. But of course, every single technique can be used with a very good result. You know, sometimes our preferences are different, but I don't mean that you cannot use titanium meshes, of course. And this is before, and this is later, the follow-up, and I have a very good result, and I was able to solve my complication. And you see that the patient has an orthodontic problem, but the patient didn't want to treat it. So I did my job, and I did vertical regeneration on both sides, but with a much better result on the left side, where I applied non-resorbable membrane. And this is the timeline of the procedure. It took me more than 1.5 years to be able to reconstruct the bone horizontally and vertically because I had a previous complication with the bone block I had to solve. So if I go to the literature, not a single technique is better than the other. What I have to do is to adapt the technique to the patient, to be able to select the proper technique for every single patient. But every technique works nicely if you are experienced with it. What is the implant survival in regenerated bone? The implant survival in regenerated bone is comparable to the survival in pristine bone, so no problem. The implant is going to be osseointegrated in that bone. Today, this is a systematic review done by Rochetta in 2008. We have clinical and histological evidence of this technique. Vertical bone regeneration works nicely. So the surgical procedure, as I said before, is based on soft tissue management. The hardest part about the GBR regeneration, vertical GBR regeneration, vertical bone augmentation is soft tissue management. The design of the incisions and the releasing of the tension of the flap. Okay, in the lower jaw, there is always a better situation. The situation is not as demanding as in the upper jaw, because in the lower jaw we have, because I went through the, because I went through the slide too quickly. Here on the right side of the screen, you can see that in the lower jaw I have two flaps. So it's much easier to release the tension of two flaps. I get my defect very easily covered with two flaps. In the upper jaw, I need more experience. and in order to release the tension of the flap, because I have only one flap, the buccal, the facial flap. You cannot stretch the palatal mucosa because everything is keratinized tissue on the palatal side. So I would recommend you to become proficient in the lower jaw before jumping to the upper jaw. And the vertical ridge incisions I apply in these clinical cases can be done with a J shape, but I usually involve the papilla, the whole papilla. And at the level of the keratinized tissue, I try to make the incision not supracrestally, but a little bit facially, without fully compromising the keratinized tissue. So I leave around 1 millimeter of keratinized tissue underneath the mucogingival junction, and then I raise the buccal or the facial flap. Okay, that's the way I design my flaps with this kind of surgeries. And of course, in order to release the tension of the flap, I have to cut the periosteum and to go between the periosteum and the mucosa, underneath the mucosa, between the muscle and the mucosa, penetrating with my blade and my periostotome in order to stretch the muscle fibers and to release completely the tension of the flap. As I said before, the mandible is easier. It's quite easy to be able to stretch the flap more than 20, 25, even 30, 35 millimeters. It seems quite complicated, but it's not so complicated. Of course, I would need a hands-on practice in order you to understand very well the technique, but at least you can see that I'm cutting the periosteum, and throughout the periosteum, by the way, you can read this nice paper published by Marco Ronda many years ago. He explains very well the anatomy of this sublingual area where the dental nerve is located, the arteries and the mylohyoid muscle, etc. And you are able to understand how to release the tension, cutting the periosteum, but also stretching the mylohyoid, the muscle fibers. Okay. And this is a drawing I did many years ago in order to understand that I'm stretching without disinserting the muscle, the mylohyoid muscle. Sorry for my, it's not easy for me to pronounce this muscle, this name. I stretch the fibers, the superior fibers of the muscle. And then here at this level, I'm not really cutting the muscle, only stretching with a kind of brushing movement with my periostotome, these muscles. And I do it at the beginning of the surgery, not the end, at the beginning. Okay, respecting the anatomy. Of course, you have to take care of the dental nerve. With a shallow incision at the periosteum and using my periostotome. And of course, I complete the suture with combining horizontal matrix sutures with simple sutures. Okay. And if I do everything properly, I'm getting good results with a very high predictability, and you can see, as you can see here on the screen. I would recommend for the beginners, I would recommend this kind of cases where I have a horizontal defect on both sides of the implants, but the vertical defect is quite mild, but consider that I usually regenerate a couple of millimeters of bone above the implant head in order to compensate the bone remodeling sometimes happens in the long term. So I do not regenerate the bone at the level of the implant head. I repeat, I prefer to regenerate 2 millimeters above the implant neck. So how do I release the tension of the flap? You can use the blade, but you can use also the scissors, introducing the scissors between the mucosa and the muscle, and stretching the scissors, and as a consequence, the muscle fibers. This is a full arch, and I have a kind of tiny video here for you to see how much I'm able to release the tension of one single flap, because as I said before, in the upper jaw I have one single flap, and you can see that I'm able to reach the posterior area of the palate with one single flap. I'm reaching almost the throat of the patient. So I'm able to reach more than 30 millimeters. In these cases, I never ever face any kind of wound adhesions. You can see on the right, after 2 weeks, everything is perfectly closed because there is not any kind of tension left there at the level of the flap. The tension is completely relieved. So what do I do with the bone? How do I prepare the bone? For the lower jaw, I prefer to perforate the cortical bone plate, not for the upper jaw. But sometimes instead of perforating the cortical bone plate, I harvest bone chips with this kind of trephines. So I kill two birds with a stone, because I'm harvesting bone chips at the same time I increase the blood supply of the area. As you can see here, I was able to harvest a lot of autogenous bone with this kind of trephines. And this is the result. This is the biopsy, and you can see that around the bone chips, the xenograft bone chips, and I have plenty of new bone. So it's working. I have real bone around the bone chips, the biomaterial. Another question is, what is the best biomaterial? Many guys are asking about that. You can use autogenous bone, of course, mixed with allograft or even xenograft. Many authors recommend 50-50, mixing 50-50, 50 autogenous bone with 50 xenograft. I try to keep to use less quantity of xenograft. I prefer autogenous bone or allograft. Allograft works nicely. I think that here I have a paper telling you that I'm able to regenerate the bone vertically without using autogenous bone, only with allograft bone. And this is quite interesting because sometimes to get a lot of autogenous bone is not easy. If you use in these huge vertical defects, any kind of different approach, I would say to you that I would prefer using more autogenous bone in these very large vertical defects than using xenograft, And you can see on the radiograph that if I'm using too much autogenous bone, it works nicely, of course, but the radiograph is a little bit different. It's a more grayish at the beginning, and then when the pass of the time, you can see that the bone gets calcified. I have new bone, and the result, of course, is amazing. You can see that when I retrieve the neurocerebral membrane, I have plenty of bone, maybe 12 millimeter white crest. The result is quite good, and you can see that I placed the implant simultaneously to the neurocerebral membrane. And when I took a biopsy, you have on the right side of the screen new bone, a lot of new bone around the bone chip, the biomaterial particles. This is the membranes we are using, but nowadays we have new designs, thank God, for these vertical defects. Before we had 30 by 40 membranes. Now we are using dense PTFE. You see you know that ePTFE is not used anymore, or I think so, because the porosity of these new membranes, dense PTFE, is lower, and we face less infection complications. So that's the reason we are using this new design of membranes, like phytoplasma. And now phytoplasma have many other sizes, and this is good for these large vertical defects. And also we have nowadays these kind of perforated membranes, which are able to stabilize the bone graft very easily, but at the same time allow the blood supply coming from the periosteum. And this is very good because the healing is quicker. And once again, I'm presenting to you a complication with bone blocks. You can see that the result is not so good. not as good as expected. So I have to retreat the site, and in order to do that, I used this kind of RPM membrane. Is the result, the radiograph CBCT, and after 9 months, I think I waited, I got a good quantity of bone. You can imagine that to harvest a second bone block from the other side of the mandible would be too morbid for the patient. It's much better to regenerate it with a new approach, changing the technique. When I place the implants simultaneously, I use this kind of rough surfaces, of course, because I accelerate the osseointegration of the implant. And the question is, why don't you wait, Ramon? Why do you place the implant simultaneously? Well, in my opinion, when I checked out the literature, I found out the survival rate and the success rate is more or less the same. And I saving morbidity and time for my patient. And that is the main reason. I have I'm saving time, cost, morbidity, and I'm using the implants as tempoles, you know. And so in the end, I'm using also less quantity, or I need less quantity of bone graft in order to regenerate the whole defect. So for me, this is a straightforward protocol, and I'm trying to save many appointments to my patient to keep things simple, because these surgeries take too much time. I need to stabilize properly the membrane, sorry, because I have to speed up a little bit because we have only 45 minutes. So for that, I use tacks and also micro screws, I think, in my opinion, micro screws are very helpful, mainly for the lingual part, because sometimes to access the lingual side is difficult with the tacks. But with the handpiece and the micro screws, is really, really easy, as you can see in this short video. You can see that they're stabilizing the non-resorbable membrane with the micro screws on the lingual side of the bone is very easy, and now I can cover the whole defect with my autogenous and xenograph bone chips. How do I suture? There are many ways to suture, but mainly I use a combination of shallow matrix sutures with a continuous suture. You can use simple sutures. I prefer continuous suture because the tension of the flap is held by the matrix suture, horizontal matrix suture. I tried deep matrix sutures in the past, but in my hands I didn't see any real difference. You can try it, you can use it, of course, but I left it because I don't see any real difference. But you can try it. And how much do I wait? Around 6 to 12 months, depending on the defect. The bigger the defect, the more I wait. The shallower the defect, the less I wait, because the healing is, the blood supply is much better. So for these defects with more than 5 millimeters of vertical component, I prefer to wait at least 9 months, between 9 months and 12 months before exposing my membrane. You can see the result. Once again, after open up, I have plenty of bone, not only on the buccal, but also on the lingual side, all around the implant. So nowadays, these kind of procedures are more predictable than ever. We need to solve complications from time to time, but the complication rate is very, very low, and we are able to reduce treatment time, morbidity, and cost if we place the implants immediately. And now, with the help of guided surgery, it's so easy and so cheap because we are able to print the surgical guides at the office. So it's not like many years ago, every surgical guide cost a lot of money. Now it's very, very cheap. And as an example, I want to share with you this clinical case where you can see on the right side of the mandible a big defect, not only horizontal, but also vertical defect. And I go for a for this kind of simultaneous implant placement with GBR procedure. I release the tension of the flaps as I explained before, the palatal flap on the palatal flap and the lingual flap and the buccal flap, sorry. I place the implants simultaneously, very easily in the 3D right position. Sometimes people ask me, how do you know where to place the implants? Because I have a digital wax-ups, previously designed. So with the surgical guide, it's really easy to stabilize the implants without any kind of problem. It takes me only a couple of minutes to place those implants because the surgical guide facilitates a lot my job. This is the dental nerve. I'm harvesting bone chips from the same site. And now I stabilize the membrane on the lingual facial bone. You can see in this picture very well the dental nerve. And I mix autogenous bone with allograft or xenograft. Stabilize properly the membrane, and I keep the membrane, I keep the membrane 1 millimeter, 1.5 millimeter at least away from the distal part of the last tooth present in the mandible. I'm using LPRF during the last, I don't remember exactly, 5-6 years in order to cover the membrane and to reduce the complication rate, the infection complication rate. It's working for me, but this is not something scientifically proven. Sorry for this. This is only a feeling, my experience. And finally, I combine horizontal matrix sutures with simple sutures and continuous sutures, as you can see here. And this is before and this is after. This is before and this is after. The CBCT, you have to be careful to place bone chips not only on the facial side of the implant and around the implant neck, but also on the lingual side. And this is the shape of the defect before and after the bone regeneration. And I open up, and this is the quantity of bone I get. Everything now is good. I expose the implant head. I connect the multi-unit abutment, and you can overcorrect a little bit with collagen membrane and bone chips. And before and after, you have the radiographs in order to check out how much bone did I get. There are many situations you face nowadays where the patient comes to the office with complications, with implant complications. So in the everyday practice, we need more and more this kind of procedures, and we need also to shorten the treatment time and the morbidity for our patient. Why so? Because the patient has been subjected to many previous surgeries, many dental procedures. You can see once again here with a simple surgical guide how easily I place 2 implants and how I go for the sinus lift, horizontal and vertical regeneration. At the same time, I placed simultaneously my implants. I close the wound, and this is in order to summarize. This is before and this is after. You see that, and you know very well that every day we are facing more and more situations like this with previous periimplantitis, biological complications, where we have to jump from this tough situation to a more predictable one, trying to avoid many appointments to our patients and trying to reduce the treatment cost. And this is before and this is after. And thanks to the new technologies, the new materials, digital workflows, etc., we are able to perform this kind of the procedures and to rehabilitate this kind of situations much quicker, easier, and with cheaper approaches. Before and after, this is the same patient. So I think I made it. It was not easy. Sorry, because I had to speed up a little bit. My conclusions are that when I place the implants at the same time, I'm going for the GBR procedure, the bone regeneration, bone augmentation, and reducing the treatment time, the cost, and the morbidity for my patient. I'm thinking I'm thinking about my patient. Okay, and how do I solve the problem with the implant position? How do I place the implant position in the perfect how do I place my implant in the perfect position, perfect 3D position with a guided surgery with a surgical guide? It's really easy nowadays to do that. Well, of course, I don't see any difference in implant survival, marginal bone loss, or prosthesis survival. You can face the same complications you face with the delayed implant placement. And soft tissue management is paramount in order to get predictable results. The implant cost is not so high nowadays. The membrane cost is much higher. If you have complication from time to time and you lose a couple of implants, in my opinion, the treatment time is more costly than the implant. So it depends on you and your preferences, of course. The final decision depends on you and your patient. And I want to thank once again Cytoplast for the kind invitation, Osteogenics, sorry, for the kind invitation, Blake and Steven for being there, and every one of you. I tried my best because we had only 45 minutes. Sometimes I lecture for 4 days about GBR, so to try to say something useful in 45 minutes is not very easy, but I hope that I was able to motivate you to train in these techniques because they work. We know nowadays much more than we knew many years ago, and the complication rates are becoming lower and lower and lower every single year because we understand much better the biology, how everything works. Thank you.
Thank you, Dr. Gómez Meda. That was a fantastic presentation. Lots of really good information there. So we'll move now to a question and answer section of our presentation tonight. Just want to remind everybody that in the top right of your screen, you'll see the button where you can type questions in. So we'd love to get to some more questions. We've already got a few that have come in. So let me, if you're okay with it, Dr. Gómez Meda, let me ask you a couple questions here. The first question is revolving around the decortications that you place, the holes in the bone. They're asking what size of burr do you use for those decortications?
The name of the burr is auto chip maker, and you have different diameters. I think I can't remember. It's around 4, 5, and 6, and of course, and also you have 2 different lengths. I cannot remember exactly. The good thing about this kind of trephine is that it has a kind of a stop. You are not able to introduce more than 4 millimeters the drill into the bone in order to avoid any damage of the dental nerve. Is really easy to use, and it takes much less effort than the safe scraper I used many years ago. You know, I've been using this kind of drill for many years with the same results.
Yeah, perfect. No, they're really effective, and I know you're not alone in using them. Looks like several people are using those now, so good answer. As far as the perforations that you create for bleeding in the patient's bone, what burr are you using for that as well? What's the size?
For the
like
tiny
a
one I use.
drill? Yeah, sorry.
Yeah, a very tiny round burr. I can't remember exactly the size, but it's around 1 millimeter, not even 2 millimeters, 1.5 millimeters, something like that. You know, it's a very tiny one. In order to be able only to reach the cancellous bone to perforate the cortical bone plate. That's the only goal to allow the blood supply to the new vessels to penetrate throughout the cortical bone plate much easier, because the new stem cells come from the periosteum, but also from the new vessels, from the vascularization area.
Great. The next question here, and I think I understand this correctly, but they're asking about the width that you graft. The question is revolving around, it looks like you go beyond the envelope of the anatomy. Maybe can you just talk a little bit about why you do that? Is it to protect the implant so you have plenty of bone, or is there another reason for the width?
Absolutely. Every time and in many disciplines in dentistry, you have to overcorrect. In many times, and in GBR, there is not a section. Sometimes when I want 8 millimeter, 8 millimeter white crest, I prefer to graft at least 10 or 12. I know for sure that sometimes I'm out of the bone in house, but this is a way to protect the bone I need around the implant body. So I know that, of course, my goal is to reach 2 millimeter of bone around the implant body. But in order to get that result, sometimes I graft 4, on the buccal side and 4 on the lingual side.
Great. Okay, the next question is around placing the membrane fixation screws. The question is, what RPM and torque settings do you use on your implant handpiece there when you're using the motor?
For the micro screws, you mean?
Right. Yes.
For the micro screws? Well, that's a good question because I'm not the one doing it. I
Sure.
work with the 3 assistants, and now I don't know for sure, but I imagine it's around 20 to 25, around that. Not too little thing, because if not, I imagine it gets stuck. But I will ask that question to my main assistant.
I'll answer
Sorry,
it.
because sometimes I've been delegated that for so many years that I cannot remember right now.
I'll answer it from osteogenics perspective, and you'll have to excuse me. But from our instructions, we actually recommend 50 to 75 RPM, and then actually start with a lower torque setting, because you want the screw to torque out once the head is flush with the bone. If you go too high on the torque, you'll just create a perforation. So there's a little balance there, but we'll wait for your answer too, because of course they'd prefer to hear from the clinician than the salesperson. But that's our recommendation here at Osteogenics.
Okay, thank you.
All right, the next question here, let me see. How do you avoid tissue perforation and the exposure of the non-resorbable membrane or barrier? I think this is, you and I were having a great discussion about this before. It's all about soft tissue management, and I think you've outlined that pretty well.
Yeah, before the lecture, we've been talking about that. Releasing the tension, cutting the periosteum, but it's not enough. Cutting the periosteum is not enough. It's enough maybe for a horizontal mild defect, but not for a vertical one. For a vertical one, you have to disinsert the muscle, the fibers, from the mucosa. In order to do that, you need to this kind of brushing movement with the periostome. There are many ways to go. The scissors, stretching with the scissors, the fibers. You have to detach the fibers from the mucosa, and that's the only way. And once you learn how to do it, I promise you that I already told you, Blake, I cannot remember last time I had a wound adhesions, but because not because myself, it works in everybody, with everybody. You have to learn how to do it, and you will get nice results, very good results.
I think, another thing you said, which I think is great before we started the presentation, was to really understand that you need to find your way to a hands-on course with yourself or with another clinician that's teaching on this topic to really understand how that release works, because it's one thing to see it in the video. It's another thing to do that in the patient's mouth and kind of trust yourself.
The problem with this lecture is a short one. Even if I show videos, the videos sometimes people don't get the idea. And this is the reason sometimes you need a picture and to practice with the picture, and you get the idea very, very quickly, because I lecture very often about this topic.
Great. Along that same line of reasoning, do you have parameters that could lead people to know exactly how much release they need? For instance, maybe they need 10 millimeters of elevation above the level of the bone where it's going to be. What are the parameters that you could set to help guide people to make sure that they have enough tissue release?
Okay, for a horizontal defect, for a horizontal bone regeneration, you need only cutting the periosteum, in my opinion. And then you can have 3 different situations. talking about vertical bone augmentation. Mild, intermediate, moderate, and severe. So for vertical bone augmentation, you need to cut the periosteum, but also to detach the fibers, the muscle fibers from the mucosa. But of course, you don't need to be very aggressive for a mild defect. For a defect around 3 millimeters, it doesn't make sense. You don't need 30 millimeters of releasing the tension. But it depends. You're working in the lower jaw or in the upper jaw. In the upper jaw, you have only one flap. Even for a moderate defect, you need to be a little bit aggressive. For in the upper jaw. That's the reason I explained before. You should start with the lower jaw. And with the lower jaw, I showed very quickly some pictures, but I didn't have the time to comment. I overcome with the flap the incisal edge of the adjacent teeth. That's the tip. Overcome. I'm not telling you to reach. I'm saying to you to overcome. For severe defects, not only overcoming, with my facial flap, I reach the lingual side of the adjacent teeth. If not, you are not doing it properly. So it's a lot. So you need a little bit of experience. You need to go step by step, because if not, maybe you get too nervous during the surgery and you get stuck. So go little by little.
That's a great segue actually into the next question. So you're obviously really far along the learning curve. You're treating massive defects, and of course you're having a fantastic result for your patients. These are life-changing results. For clinicians that aren't as experienced and aren't as comfortable releasing the large flaps, of course you recommend with the beginning types of cases, but are there a few, I don't know, basic level cases that you would recommend clinicians to start as they begin this learning process?
You need, of course, first of all, you need to practice in the big jaw. Of course, sure. You need, but you need also experience with mucogingival surgery, because from time to time you will need to harvest a CTG. I don't want to explain too much about that, but for sure you will need vestibuloplasty plus free gingival graft, in order to increase the band of keratinized tissue during the second stage, or sometimes a Cathayan vestibuloplasty. So you cannot be successful only learning exclusively the GBR procedure, the GBR protocol. You need much more, in my opinion.
Yeah, it's a great point. It's one thing to solve the bony defect, but then you also have to do something with the soft tissue that you've now displaced in order to have the primary.
Yeah, because after the problem with this kind of defect is afterwards. Of course, in 45 minutes, I cannot do it, but I have lectures about soft tissue management after the bone augmentation procedure. And afterwards, you know that you don't have any vestibule. Sometimes you don't have enough keratinized tissue. Other times you are in the upper jaw and you need not only a free gingival graft, but another kind of grafts.
Great. So I think we've got enough time for maybe two more questions. I think this one's actually fairly straightforward. So how much time in months does it take for a vertical versus horizontal ridge augmentation?
Horizontal is around, with horizontal, I open up always after 6 months. More than enough, okay, in my opinion. But with vertical, the larger the defect, the more I wait, from 9 to 12 months.
And then the kind of the follow-up to that question is, how do you set expectations with the patient when they're going to be, healing for those long periods of time?
Yeah, that's something that we should speak about when during the first slides. But once again, I didn't have much time. And this is about case selection. Of course, not every patient should be treated should undergo this kind of procedures, because not every patient is prepared for this. Sometimes it takes you 1.5 years, even more, to complete the whole procedure. I mean, with the rehabilitation, with the prosthesis. So you have to be sure that the patient understands how difficult this procedure is, and also from time to time you can face complications, and some patients are not able to face complications. They don't understand complications. You need a little bit of experience in order to select properly the right patient, because you cannot do this kind of procedures in every single patient, in my opinion.
Yeah, I think patient selection is key. So I'm going to ask you a question here that I know is going to take you a long time to answer, but I'll ask for your kind of abbreviated version here, because I've heard you talk about this in the past. But in your cases, well, let me step back just a second. For a lot of people, they want to stage this out. So they have vertical ridge augmentation, and then they place the implants after the healing time frame. You have a different philosophy for that, and you believe that you should place the implants at the time of grafting. Can you just briefly explain what you see as the benefits to placing the implants at the time of augmentation?
Yeah, as I said before, firstly, nothing wrong about delaying the implant placement, of course,
Sure.
going step by step. Secondly, as I said before, is about saving time, cost, and morbidity. The problem is that we already said that for severe defects, we have to wait a lot. If I place the implant simultaneously, I'm gaining many months, because the implant is already osseointegrated. Then when I expose, when I retrieve, when I remove the membrane, I can regraft the site if I want, and if I need to. Nothing wrong with that. You could do it when you place your implant with a delayed approach, but I have more opportunities. That's my approach. That's what I think about. Think that about this. For severe defects, bone augmentation is not enough. You need always soft tissue grafting, vestibuloplasty, free gingival graft, CTGs, and sometimes more than once. It is published. So sometimes, if you go step by step, maybe it takes you 2 years to complete the case, because afterwards you have in aesthetic area you need professionals, and you need to shape the emergence profile, and you need to wait a lot of time in order to get the stable long-term result. So it's a lot of time. It's challenging. And that's the reason I prefer to place in 98% of my cases, when I can stabilize the implants, I place the implants simultaneously. And in almost every case, I'm able to stabilize. With only 3 millimeters of bone left, I'm able to stabilize the implants, because nowadays implant designs are more aggressive, with more aggressive threads. They are easy to stabilize.
Well, thank you for reiterating that point. I know you already discussed it in the presentation, but I think it's good to hear your philosophy on that topic one more time here at the end. So I think we've had a lot of great information here. We'll go ahead and close off there for the night. So I want to thank everybody for watching the presentation. We really appreciate it. I think there's, again, lots of really good bits of knowledge here from Dr. Gómez Meda. So Dr. Gómez Meda, thank you so much for your time, and we look forward to doing this again in the future. Thanks, everybody.
Thank you, Lake. Thank you, Stephen. Thank you, everybody. Good night. Bye-bye.
Thank you. Good night.